Good morning, everyone. I am Kelly Mercier. I am the DTRF Natural History Study Principal Investigator. Earlier this year, we had this abstract presented at ESMO Sarcoma and Rare Tumors, and I'm going to go through the data and hopefully have some interesting discussion with you. My brain was on this presentation. I have so many questions for Peter now that I just wasn't able to fully digest, but I hope that during the talk and conversation later, we can all come back to patient-centric metrics and understanding their experiences. So thank you so much for the time today. I will be discussing the association of pain with function for adult patients with desmoid tumors. So this presentation was supported by SpringWorks. We've had an ongoing collaboration with them looking at the natural history study data. I am an employee of Daiichi Sankyo, which is an oncology pharmaceutical company where I work as a diagnostic medical director. I'm also associated with the DTRF and Duke University. No conflicts of interest related to this presentation or interests or research. So I think I come to you all every year and talk about the natural history study. I see a lot of familiar faces, but some new ones as well. This is a collaboration that we have with the National Organization of Rare Disorders. We have been collecting data since 2017. The NHS has a total of 15 surveys. 7 of them were designed to describe rare disorders in general, and the additional surveys were designed for desmoid tumors in particular. A couple of years ago, we incorporated 2 additional ones that have to do with caregiver burden and financial toxicity. Sophia from SpringWorks will be giving a presentation on her abstracts that we've also presented this year at ISPOR. At the patient meeting tomorrow, I highly suggest that you, if you're able to, attend her presentation. It's very interesting data that we were able to identify from the patients and their financial burden of disease. So in this study, we wanted to understand the association between pain and function. So we know that pain represents a clinical symptom of desmoid tumors, and we wanted to use the Goddess patient-reported outcomes tool to look at these associations. So there are 2 different modules under the Gounder module. Thank you, Mernal, for that work that you did a number of years ago. So under the DTSS, we have the pain domain, and those include different questions relating to shooting, dull, and worsened pains. And so the higher the score, the higher the pain level. Function comes from the TDIS module, which incorporates function, so sleep, physical, emotional. And again, we have this 10-point scale. The higher the scores, the more severe the symptoms. And so we were looking for an association between pain and each one of these domains from the DTIS. And then we did some subgroup analysis that ends up being interesting. So the study for this analysis included 335 participants. You can see that it matches a lot of the demographics that we saw from Peter's evaluation in terms of percentages. So we had 73% of the respondents were female. Most of them were white. We have a distribution of countries of residence, although primarily in the United States. You can see the breakdown of desmoid tumor location with 35% extra-abdominal, 20 abdominal wall, 24% intra, and 28% joint and extremity. Interestingly, we also capture whether or not the respondents have a desmoid tumor at the time of response. And yes, obviously, means that they currently have a tumor in their body. No, meaning they've had some kind of intervention that has led to a removal or successful treatment. All right, so here's the meat. So what we saw is overall there was moderate to strong correlations between pain and function domains across all of the patient subgroups. On the left, we have the overall, showing each one of these modules as being significant with p-values of less than 0.0001, and that's for all 335 respondents. For each one of the subgroups, we can see that in the presence of a tumor, we have greater association with pain for sleep and physical functioning, whereas the absence of a tumor has a greater association with pain and emotional impact. We can see that there's a trend in the tumor location subgroups with the joint and extremities having a higher association, and then sleep and functioning. We can look at this on the far right with treatment history having a prior desmoid tumor treatment versus the emotional impact of no treatment having a stronger correlation than having a prior treatment. So interesting differences between these subgroups. When we looked at uncontrolled pain versus pain, there are also some interesting notes and trends. We can see that the DTSS, we classified uncontrolled pain as being greater than or equal to 4. Everything less than 4 was controlled. So all of these emotional impacts seem to have a greater association with this uncontrolled pain. We can see this through sleep, and we can also see this through physical functioning. All of these, again, noted as significant. So the conclusion is that uncontrolled pain has clinical meaningful worse sleep scores, physical functioning, emotional impact. We know this from talking to patients in clinic at this meeting, and these patients can experience this in their everyday life, impacts everything in their lives, from jobs to well-being, and it's important that we incorporate this knowledge when we are engaging with them and treating them and planning for their future, because it does last a lifetime, as Peter described, years and years being out from diagnosis. It's really important that we have these things in mind when we're working with them and incorporating multidisciplinary care. I couldn't have done this study without my colleagues at the DTRF and at SpringWorks. The patients who participate every year in this study, we query them at least once a year. Couldn't have done this without the natural history study, investigators and staff members, and I thank you for your time this morning.
Kelly, may I ask you a question?
Absolutely.
Yeah, so I was intrigued by the data you presented about patients who did not have a disease. In other words, either were affected or in remission, and yet many of their symptoms were quite high. Do you have any insight as to what's driving that?
I think that patients have this anxiety or fear of disease coming back. I think that they have long-term impact from the treatments that they received. And I think that we as a community, for instance, haven't done historically a great job with fertility discussions. I think having all of these things in the forefront will help patients, but symptomatically, I think that the treatments that have been chosen, the modalities that have been chosen, just have long-term impact as well.
Yeah, I mean, it's quite striking that the emotional impact is even worse than people who have ongoing disease.
Right. Yes, Peter.
Can you figure out from your database the impact of different pain treatment on the intensity of pain reporting? Which one is the best or worst? Or?
Yeah, that's a good question. We do collect data on pain management, and I would have to look at how well that could be powered, but that's a great suggestion. Are you taking notes, Sophia?
Could I ask you a follow-up?
Okay, hi. I just have a question. Do you know like how many of your patients have like supportive care integrated into their team?
Yes, I believe there is a way for us to query that in our database. We have incorporated additional questions in the past couple of years, and I believe that was a part of our update. So if you ask me again after I sit down, I can take a look for sure. If there's anything in particular that you're interested in, social worker or housing or financial support, happy to look at the data. Yeah.
Yeah, so I'm curious to ask whether this is unique and specific to desmoid tumors, or is this a survivorship problem in oncology?
Yeah, that's a great question. I don't know. We have not compared. In Sophia's data tomorrow, we have compared financial toxicity to malignancies, and it's right up there. So I imagine that it could be similar for long-term survivors with melanoma, right? If you think about the longest outcomes that we have for solid tumors, yeah, possibly. If you have any suggestion of tumor types to look at for long-term emotional impact, I would be absolutely interested in looking at that. Okay, yes, hi.
Physical functioning is a pretty broad class. How do you break that down? I mean, physical functioning, impaired mobility post-operatively, physical functioning from pain causing you can't walk. How do you, because I mean, if it's like post-operative disability, that may persist for the whole lifetime of the patient versus pain that's ongoing, either on therapy, off therapy, what have you. So how do you define physical function? Maybe you did that, I missed that, but how do you define that?
So there's a subset of questions in the DTIS that has to do with that, and it has to do with daily activities. I'd be happy, or Manal can share with you what the questions are that lead into there, but they have to do with day-to-day activities.
Okay. So it could be any type of physical impairment. Basically.
Yes, from what I recall.
Okay. Thank you.
Awesome. Thank you so much. Happy to talk with anyone afterwards.